Hey, everybody. We are starting a live session. You probably have heard me talk about this all week on reproductive surgeries. So we're going to give everybody a few minutes to pop in. Hi, Mom Life Problems. Hi, Santa. I'm happy to see you. This is great. There is a plan. Yes, there is. Erica Myers, Jas joining. We have a very special guest, and he is a newbie at Instagram Live, and I'm so excited to have him on our show today because we're covering reproductive surgeries. So if you know someone who has fibroids, or if you yourself has fibroids or endometriosis or something else, Jas, we do speak Spanish, not me, although I'm taking Spanish class with my son. But yes, we have a Spanish-speaking staff. We do. So Jas, please DM us in Spanish, no problem. Okay, Dr. Gunnala is joining us from Southwest Fertility Center. This is his first time joining us, so he is going to hop on his Instagram. There he is, and he's going to click request to come live with me. And once he's live, let's see if I can add him too. And I think maybe make it easier on him.
We are starting a live session.
All right, let's see. We're going to go down. I think he's getting there. All right, everybody, bear with us while I get him on. This is his first time, and we're going to help make this a smooth transition for him. There he is. So Vinnay, join that, and we'll get this conversation going. There he is. Oh, good. Okay, first of all, round of applause. We did it. Okay, the first connect is always the hardest, but we did it. So this is really exciting. Thank you so much for joining our community, and we're so grateful for all the answers you've been providing on the Fertility Answers app already.
Thank you so much. No, it's a great app and a great program to kind of spread erase misinformation to fertility, which is rampant and all over. So no, it's
exactly. All right, this is great. And Steve Schultz, we already have some questions coming in, so I'm going to tee up the context of the dialogue for everyone who's watching. Many people do assume that IUI and IVF are the only options for treating different types of infertility, but we know that's not true. And it is actually rare to have an IVF clinic that has this specialty of reproductive surgery because not everybody wants to be doing surgeries when they become an IVF doctor.
Right.
But you have this unique practice, so back everybody up and kind of and just give everybody a little bit of an insight into how cool it is that you're the only mother and son practice in the entire country.
Yeah, so pretty blessed in it. My job interview application was much smaller and much shorter than all of the other people graduating into the family. But so kind of a little bit of the backstory is that my mother is an REI, still practicing and still pushing it. And she started the practice in 1980. So, when she started her practice, that was when really just the first IVF baby was born in London 2 years before that. So she was really in the inception of the field when things were not as advanced and as technologically savvy and as what we have now. So she's kind of seen it from the beginning to the end. And so she's always been kind of practicing by herself. And then slowly as I kind of got more interest into women's health and then medicine and then fertility, it was this kind of natural snowball in a good way of just kind of loving this area of the field and this specialty. And then thankfully after I did my residency and training in New York, then got to come home and practice with her.
And you guys are in Arizona, so you do serve not just folks in Arizona, but you also serve people in New Mexico and probably Southwest Colorado and maybe even parts of Texas, right? People come from all over to access your practice.
Yeah, no, I mean, I think that's one of the many things, the benefits of this field is that there are a lot of practices all over, and now practices all over, not just ours, but have been accustomed to kind of manage patients and treat them when they don't live locally in their center. And so we're no different than any others, but right, we have patients coming from a lot of New Mexico where there aren't that many fertility centers right now. Southwest Colorado, like you said, where there's really, I think, only actually 2 OBGYN practices, and there was an REI there, but he retired. We get some from kind of the Northwest also and Vegas and California. So, I think people do come all over.
Well, it's amazing. And some of these procedures aren't always covered by insurance either. So, I mean, even some of the common ones, we are asked all the time about reversing tubal ligations, right?
Yes.
So that's not one that an insurance company typically covers. And you are a very affordable practice. So a lot of people probably come to you for that reason too.
Absolutely. Absolutely. The large majority of surgeries that we do with a reproductive kind of fertility indication can still be billed through regular insurance because they all also carry gynecologic reasons for doing it. But the one caveat is that is the tubal reversal surgery.
Right. Got it. Okay. So let's actually jump in, and we're going to get to your question. C. Schultz, hang in for me for just a minute. Can you explain the conditions which might be treated surgically and then the instances when they might be preferable to jumping into IVF itself?
I think first and foremost is you got to look at the complete picture. I think somebody can say, well, I've got a fibroid. Should I take it out? And I never want to beat around the bush, but I say that, well, first is let's get a complete diagnostic workup because you've got to look at the fallopian tubes. You've got to check your husband's or your partner's semen analysis, and you've got to look at that woman's ovarian reserve. It really is that full picture before we can say, should we take care of this surgically or not?
Right.
There could be, for example, a tubal reversal surgery is something that we can do with definite. It has to have some strict indications for doing it. There's no doubt it carries some risks, but IVF is not for everybody. But for example, if that partner in her second marriage now has a very low sperm count, and that's already an indication for why would you go through the tubal reversal surgery, which is a big surgery, carries some risks, is not a guarantee when that couple needs IVF anyways from a male factor. So, you really have to look at the full, complete picture, and that does take that diagnostic workup. So I would say that's where you start.
I think that's really wise. And we had some folks coming on in particular about fibroids earlier in this week, kind of saying that, well, like, how do I know if that fibroid needs to come out or not? And it's, can you talk through maybe some of those considerations too, like placement or size or
absolutely
symptoms?
So definitely I think a woman's symptoms are important to take into consideration, not only fertility, but if they're having kind of heavy menstrual cycles, that's a common symptom of fibroids, or if they're having kind of any what we call bulk symptoms where those subserosal or fibroids outside of the uterus are really causing kind of chronic pelvic pain, chronic abdominal GI issues or urinary issues, then those would be, I think, gynecologic indications for doing the surgery. From a fertility standpoint, it really depends on more location, to be honest, more than anything. If it's anything in the cavity, it's got to go because that's where baby's going to stick. So that can definitely block implantation and also increase the risk of miscarriages. The ones that are in the muscle take a little bit more of a kind of a nuanced approach, and that's where the fertility workup comes in, where if that fibroid is dominant size of greater than about 4 to 5 centimeters and very close to the cavity, where within about 5 millimeters, that even though it's not in the cavity specific, but it's so close and it's of a size greater than 5 millimeters, that's also a fibroid that in studies have shown should be taken out because it does impact just the ability of that embryo to implant, even though it's not in the cavity. So the ones that we really take out are definitely ones with any intracavitary component, so in the cavity itself, or if they cause like cavitary distortion. So if it's a big fibroid in the muscle, but it's kind of causing the cavity rather than to be a perfect triangle, but be kind of caved in on one side, that's also a fibroid that probably needs to come out surgically.
Okay, super helpful. We're going to jump into a couple questions and then jump back to my questions, make sure we cover all the ground. Steve Schultz had endometriosis surgery in May. However, they left the spot outside her fallopian tube. She says she has gotten pregnant before, but never passed chemical loss, never passed the first few weeks. Wondering if this spot absolutely needs to be removed. So she has not gotten pregnant since.
And it's on the fallopian tube?
It says it's just outside.
Okay. Definitely kind of endometriosis and surgeries. Surgery is a perfect explanation of where kind of endometriosis can be handled and improve that couple's chances of getting pregnant both in nature and with less aggressive techniques like an IUI. So, and that is merely just by burning or resecting the small peritoneal lesions of endometriosis. Whether we take that into effect is you have to take everything from a fertility standpoint, right? And so what we're trying to do is optimize her fertility. And if me taking care of that lesion would compromise her overall health currently and put her health at risk just by the location of it, then we wouldn't want to address it. But if it could be removed or burned and fulgurated easily without affecting the compromising the ability of the fallopian tube to be working, then I would take care of that. But It sounds like she also just had a recent surgery. So I don't know if we want to go back for another surgery just for that small lesion either.
Got it. Now, do we need to be concerned about scar tissue in that area if you do take that out and it's so close to the fallopian tube that scar tissue might block the tube?
Right. So, I mean, I think with any surgery, especially a laparoscopic surgery, you get more benefit from the first one that you do and the second one. But the more that you do, you actually get less benefit from each one and more risk, because each surgery, even just by sticking a camera in and looking, can sometimes cause like minimal scar tissue. So, it's not to say we definitely use surgery a lot with patients with endometriosis. And I think that's where it really definitely applies. But, in somebody that's had multiple surgeries with endometriosis previously, you're going to be less inclined to operate because, one, it didn't work that well before if they didn't get pregnant. And now more surgeries are just going to be causing more risk of scar tissue with less benefit.
Okay, got it. All right. We have a couple of questions that are IVF related, not necessarily surgical related, but I would like to address these too. Lauren, who's a repeat
community for LaCroix, even though I'm a big fan.
Lauren has come back many times on our episode. So we've been tracking Lauren's case. So she got her genetic testing done on her embryos. 3 came back normal. She transferred 1, which resulted in a blighted ovum though. What could have happened?
It's tough. I'm sorry, first of all. Obviously, we had a really tough journey to go through it of going through all the testing and getting pregnant and not being a healthy pregnancy. Unfortunately, as much as we can control with IVF and biopsying of embryos and putting back a genetically normal embryo, it still can't guarantee a pregnancy. And it also can't eliminate the risk of an early pregnancy loss. So that pregnancy loss still, even when we put a biopsy proven genetically euploid or normal embryo, the rate of a clinical miscarriage is about 10%, and the rate of a chemical pregnancy, which she had, is about another 10%. So 5 to 10%. So you're still looking at a risk of a miscarriage of about 10 to 15% in those patients when you're putting a genetically normal embryo back. So one is it's not rare, and that doesn't make it any easier. In terms of why it was a chemical pregnancy, I would do the basics first. Don't look for the zebras, but let's make sure that the cavity of the uterus is normal, that there's no polyps, no fibroids, nothing like that. And you can do some autoimmune testing because you can consider it as a early pregnancy loss of a genetically normal embryo, and therefore some autoimmune testing would be indicated, I believe. And then lastly there is some indication that not necessarily in clinical miscarriages, but if it's a failed implantation or a chemical pregnancy like she had, then it could be a problem of timing of the embryo transfer, and an ERA may be indicated.
Okay, that was a fantastic answer. So comprehensive. Lauren, I hope that helped. He is one of the things that I love about Dr. Gunnala is he's very clear of a communicator of all the medical things, but in a way that we can understand and digest. So I have a little follow-up that I have to add.
But thank you for the compliment.
All right. And Seashell had a follow-up on her first question regarding the endo surgery. She also has PCOS. So we see this all the time, people who have endo and PCOS and just have this double whammy. How common do you see that in your practice too?
Relatively common. The two are actually completely separate. So a woman having PCOS does not increase her risk of having endometriosis and vice versa, but absolutely
just super unlucky.
The two processes, could be going, and they got stuck with that,
Right. She did recently have lipo on her stomach. She's wondering, is there any information on better chances of pregnancy after weight loss surgery? So this is more maybe in the whole sort of metabolic syndrome realm of PCOS and it making it difficult to lose weight.
Absolutely. I mean, I think in terms of PCOS, really the problem is that a woman is not ovulating regularly. And that makes timing of intercourse is absolutely crucial, where that sperm needs to be there before a woman ovulates. And if we don't have kind of regular monthly menstrual cycles, it just makes it nearly impossible. Not can't happen, but it makes it hard. And so, the best management, long-term management of PCOS is kind of the lifestyle changes that are hard to do, but of kind of diet, exercise, and weight loss, if we think that is playing a role into that woman's kind of irregular cycles. And so I think surgery for a bariatric surgery, as long as that is accompanied with lifestyle changes of diet, exercise, and weight loss, then we can keep that weight down. And that could be actually the best treatment to have that woman start ovulating regularly. And now what was an issue for many years is no longer an issue. And you could actually just kind of try on your own if all of the other factors were in our favor. So,
and I would say, C. Schultz, you've also been through a lot this year. She's had 2 massive procedures. So yeah, you're a warrior. So also take a minute for some self-care, take a minute to kind of recover and recoup and do all the self-care loving things that we're always advocating for infertility patients to embark on. Where you do clean up your diet and lifestyle as much as you can, and just know that you're on the right path. But I do just want to acknowledge that she's been through a lot in the quest to have her dream come true. And we know that that's not easy, and it probably wasn't easy decision making either for having to do both. So we really acknowledge you there. Lots of courage in our community for sure. Coffee and Glitter. Let's see. I love that. Coffee and Glitter Mom. Oh my gosh, that's such a great handle. I dropped the glitter though, because when the first and only time that my son took glitter everywhere. And for those of you who are just getting to know me, my son is an IVF baby. He was a frozen day 2 embryo for 5 years, and he, who doesn't love some glitter? But it never comes out. It's in crannies and crevices all over your house. So she recently had a hysteroscopy. She'll be having another in December to address some scar tissue from her C-section, which is also pretty darn common to hear about scar tissues from C-sections. She did have a D&C 3 weeks post C-section, and they think it caused a lot of scar tissue. Is that common to do a D&C after a C-section?
So probably what happened is not necessarily related to the C-section, but I assume that we had some type of kind of right after delivery, postpartum heavy bleeding. And that can sometimes happen either if there is possibly that she had an infection of the placental unit after it delivered, and that's a risk factor of heavy postpartum bleeding, or that there, even though it was a C-section, there could sometimes be some retained placental products there that could cause postpartum bleeding. She is kind of set up for, in that situation of, what happens physiologically is after we deliver, there's a huge drop in a woman's estrogen level because we just expelled the pregnancy, we got the baby. And so now your body is kind of slowly getting back to that normal physiologic state. And it's in that withdrawal of estrogen that if there is any instrumentation in the uterus, which she had the D&C, which was instrumentation, there's a very high risk of then developing what we call Asherman syndrome, which is uterine scar tissue. And one of the biggest risk factors for that is having some type of a uterine procedure right after delivery.
Got it. Is there anything that she can do about that scar tissue? Is that going to prevent a successful pregnancy?
How it can definitely impact a woman's fertility is that there's just less viable endometrium or less viable uterine lining. And in severe cases, actually, it can present with a woman not having any menstrual cycle. So she's still ovulating every month, but there's no viable endometrium, so she doesn't have a menstrual cycle. Or it could be kind of grades of it where maybe some of the uterus, a percentage of it is scarred off, and now she has much less menstrual flow, like maybe only 1 to 2 days when she normally had 5 to 6 days of flow. So there's different grades of it. It's a hard thing to treat, but definitely something that I think a good fertility surgeon that feels comfortable with it can do. And that is where hysteroscopically they go in and they resect the scar tissue that they can see. You don't want to be overly aggressive, but you also don't want to be under aggressive. So sometimes it does require multiple surgeries. I think what's also important in these patients is post-op prevention of Asherman's coming back in scar tissue. And so there's a lot of data out there, and just kind of where I trained at Cornell, we've got a pretty good kind of protocol of what we use, where we put in a balloon into the uterus for about a week and then basically build a menstrual cycle around that by giving that woman extra estrogen and then progesterone. And we think the combination of hormonal therapy and the mechanical separation of a very tiny balloon, that personally in my surgical experience, that's shown to be very good in terms of reducing the risk of Asherman's after the uterine surgery.
Oh, got it. That's amazing. Okay, I'm so glad that you told us that. So coffee and glitter, did you get that? So since you're having another procedure in December, maybe bring up and where could she actually go find out about that? If she just goes onto the Cornell website, would it actually break down kind of that procedure?
I don't think so. I don't think so. I mean, I think to be honest, in the data, there's, Ashermans and these kind of things are, like I said, there's just so many different grades of it where somebody could have something minimal, but that's very different than a severe case. And I think, so there's some data that says you take care of it surgically, you don't need to do anything. And then there's some data that says you take care of it and just put them on hormonal therapy, and other data that says you take care of it and maybe put the balloon in, but don't do anything else. I think everything has to be treated individually, but if your surgeon was obviously already capable of addressing this and comfortable addressing it surgically. So, I think a very reasonable question would be, well, is there anything after surgery that we can do in terms of hormones or mechanical separation of the uterus to reduce the risk of it coming back?
Excellent. That's what I wanted to get to. Is like, that's the perfect question for her to ask. That's perfect. Thank you so much. That was amazing, Dr. Gunnala. All right. We have Irvine Ashley, had endometriosis 15 years. A lot of suffering there. A lot of suffering. I understand that. She did IVF, 4 failed transfers, but never had a laparoscopy. Should she have a laparoscopy before attempting second round of IVF? They diagnosed endo by I'm thinking by internal something. Let me see if she added to that. Yeah.
So, the question on whether to address endometriosis with laparoscopy goes back to the beginning of, you got to look at the complete picture. One is, it's very common. So 15% of women will have it worldwide, but about 35 to 40% of patients that are having difficulty conceiving will come in with it. So it's something that a fertility specialist always has to have in the back of their mind, even when that woman doesn't have the classic symptoms of like debilitating painful periods, pain with intercourse, pain with bowel movements, pain with urination. So it's always there. I think the stage of endometriosis is important to know on whether you should address it. And why that's a little bit of a frustrating answer is that you can only diagnose endometriosis really by surgery and know the extent of it by surgery. So how we use, that is, one is, if the patient's symptoms are debilitating and she needs it from a gynecologic perspective, then you've got a strong indication for doing surgery right away. If the other workup is completely normal, you could start with less aggressive treatments like IUI. But if they don't get pregnant in the first 2 to 3 cycles, which is when the majority of couples will, at that point, I really strongly recommend laparoscopy for endometriosis, especially if that couple wants to continue with less aggressive approaches. Because taking care of endometriosis surgically, resecting it or burning it, especially if it's only stage 1 or stage 2, that absolutely increases the chances of getting pregnant with less aggressive treatment in the next 3 to 6 months. So you can use the surgery as a way of increasing that couple's chance of getting pregnant, knowing that they're going to continue in a kind of less aggressive approach like IUIs or even, timed intercourse and trying naturally.
Amazing. Okay.
With IVF, you do get a little bit less benefit for endometriosis when you do laparoscopy. So IVF generally puts patients with endometriosis almost nearly at a level playing field. Now, obviously, she's gone through a full cycle of IVF with multiple transfers. Right. I think at this point, depending on what those embryos looked like and what the prognosis was, if you would have thought that we should have established and had a healthy pregnancy at that point and haven't, now you got to start picking up other rocks and looking under them. And I think a very low risk option is taking surgery and doing endometriosis, because endometriosis will absolutely, by resecting it, will definitely reduce that inflammatory environment in that woman's pelvis, and therefore does improve the ability of an embryo to implant.
Got it. That makes perfect sense. I hope you guys are loving this as much as I am, because that was, again, such a clear answer. Yeah, Mr. 80, what is natural FET? Do you prefer natural cycle or hormonal FET? I think I know his answer to that.
Absolutely. I have no preference. I think clinics so there's really not a major, not any difference between the two. Sometimes there's patients that have a better lining in a natural FET than in a program cycle, then absolutely go to a natural FET. I would say that the majority of clinics do a programmed FET cycle, as we do, just because logistically it's much easier. And so you can then time the transfer, you can schedule it, versus a natural FET, you have to wait for that woman to ovulate, and then really for the next 2 to 3 days after that, you've got to get blood work to know exactly the day that she ovulates, so you know that you're putting the embryo back at the same day, or at the correct day. So there's no difference between the two in terms of study wise, but I think the benefits of the program cycle are that it's much more scheduled and structured. The benefits of the natural cycle is that if you've got a normal ovulation and you ovulate regularly, then then you may not even need, injection to trigger your ovulation. And some clinics wouldn't even put you on progesterone injections because we're using your own body's ovulation to support the pregnancy of the embryo that we put back. So I think there's benefits to both, but really no major difference clinically between the two.
That's amazing. When I got to week 9 and I stopped doing my progesterone injections, I actually felt like, I was so used to it. And then I felt like I had nothing to do except taking my prenatal. Yeah. So as much as it hurt and my tush was black and blue, I felt empowered. Like, well, I'm doing something. To support the pregnancy, and I was so nervous when it was time to stop those injections. Yeah. But I love your approach. I think it's just like, it gives us a chance to feel empowered, like we're part of the decision making, rather than this is my prescription and everybody has to go by this.
Yeah,
which is awesome. So C. Schultz is just confirming that where the endo spot was in front of the fallopian tube, the surgeon did not want to remove it. So there was some clinical reason the surgeon did not feel comfortable removing it.
I would say that, and once again, I love surgery, and I think that's why I do it. I happen to get trained in an institution that also loves surgery and appreciate it, just how many attendings we had. But there is an unfortunate trend that I do feel is unfortunate, where it's easier for REI fertility specialists to do IVF. Our reimbursement is better with IVF than it is with surgery now. And also there's other kind of minimally invasive GYN surgeons that have now kind of gone into its own field where they're very capable and good surgeons. Whereas, historically, when my mom started her practice, the best gynecologic surgeons, minimally invasive, were your infertility specialists. Because it really began as a surgical subspecialty, because that's all we had. We didn't have IVF, have all the injections and all the medications. So it started that way, and definitely it's getting less and less, but there's definitely a role for surgery. And I would also, kind of comment that I think that shows a great kind of a level of caution in the surgeon that did that for the last patient, just because. And this is one thing that I'm still learning, but it's very easy to be overly aggressive. But I think you have to learn as a surgeon of, why are we doing this? Should I stop here, and when to stop? And when something is there that you can take care of, but if it's going to cause more harm and not help, then I think that's actually the biggest kind of skill that a surgeon needs to have. Not when to go for it, but also when to kind of take a step back.
I love that approach. That's so important.
And I'm still learning that. There's no doubt about it.
Right. So important. So Coffee and Glitter following up too, on her case, her doctor couldn't get into her uterus due to it, and was diagnosed with Asherman syndrome, but isn't sure if there's any more scar tissue in the uterus aside from one spot she saw from 2 miscarriages.
So that's it tells me right there, if the doctor couldn't get into the uterus even there, then it's at this point a very severe case. The scar tissue and the obliteration could actually be more just kind of in the cervix, and maybe not in the body of the uterus.
Okay.
And so there's just a problem of getting into where we need to go. Or it could be a problem of actually the whole cavity is just completely shut and scarred down. And that, we can attempt to try. And once again, it would just be kind of informed decision making that this is as severe as it gets, and we can try, and we may need multiple surgeries, but that one's going to be a hard one. If you can't restore it into a normal cavity, then then we are limited, and the last thing you would want to do is waste an embryo or embryos on a uterus that isn't going to be able to take the pregnancy. But I think as long as we're trying, then and give it a shot. There's no doubt, and no negative of trying. Just a lower chance.
Okay. I know that sounds like something very difficult for you to be going through right now too. You know, you got to be able to see inside. So yeah, if you're stuck, I remember one doctor told me I had cervical stenosis, but then my second doctor was like, no, you don't. So I went into my transfer thinking that, that we were going to need extra help. And he's like, you don't have that.
Yeah. No,
like,
no.
That happens. One person has this view and the other person gets in there and is like, nope, that's not it.
Absolutely.
So Frenchie Jen is asking, is it common to remove polyps and not be put under anesthesia?
Probably about 10 years ago, no, but now there are, surgical techniques and just instruments are advancing very, very quickly, both in terms of putting a catheter in that now may have the ability to just grab that small polyp and take it out. And so, I personally don't. So any type of operative management, whether it's obviously a fibroid for sure, scar tissue for sure, polyps if it's very small, sometimes you can go in diagnostically with a very small camera and just kind of snip it out. If it's very small and tiny, then yeah, you could do it without anesthesia. But if it's a bigger polyp or there's more than one, then generally those need some type of light sedation through the IV. But we do diagnostic hysteroscopies in the office just to look for scar tissue, or just when our kind of diagnostic workup is not 100% correct, and where it's a little bit equivocal, then we do that. And those instruments, because they've advanced now, you can kind of actually put a scissor through that. And yes, if I did see a tiny polyp and the patient was tolerating it well, I could just go in there and kind of snip it out.
That's amazing. Do you guys have any of your surgeries on YouTube? I want to see that tiny little scissors going in the tube.
we don't. No, but that's the light bulb went off. I don't know.
Okay. All right. Good. Okay. We got to get on that, because I think, those of us who are in this space and trying to do all these things, it does help actually to see some of these procedures. C. Schultz, you're welcome. So glad that helped. Coffee and Glitter following up some more. Are there different levels of Asherman syndrome like there are with endometriosis?
There are, but the kind of the stages of endometriosis, I think, are much more defined in terms of kind of how many lesions we have. Are they deep? Are they peritoneal? Where is it located? Is it above the pelvis, in the pelvis, in the ovary? So that staging system is much more unified and understood. I think in terms of Asherman's, we really just use kind of a mild, minimal, moderate, severe, and then it would take kind of that fertility specialist or that surgeon saying kind of how much of the cavity is obliterated. I think rather than giving it a grade 1, grade 2, grade 3, grade 4, that we don't have, but you can verbally, express what you see, and you can say, it's a moderate amount with 25% of the cavity obliterated and scarred down, and that would be, what I would use more commonly.
So in her case, best case scenario is the scar tissue is blocking entrance, blocking the cervix, and that's the worst of it. And that they get into the uterus and actually find that there's not as much.
That would be, I think, the best case scenario.
Okay. So hopefully that's helpful, Coffee and Glitter. So we always like to give people, the hope to hang on to as well, and not go in with utter worry, but knowing what questions to ask, and is there anything on imaging that can show up with that, or do they truly just have to get in there and actually see what's going on?
No, but the uterus. Yeah, absolutely. So the uterus is perfect, or the lining of the uterus is perfect in that it reacts to the hormones that come from the ovary. So if a woman is having regular menstrual cycles and ovulating, then as that follicle grows and grows and produces estrogen, we should see a lining of the uterus thicken and kind of develop that trilaminar pattern that we want to see. So if I saw that in kind of just a regular diagnostic cycle, that would give me a better idea that, okay, there is still functional endometrium and lining there that could implant. But if during a diagnostic cycle, when we know she's ovulating and that lining of the uterus stays very, very thin and never kind of thickens, that's a little bit of a poorer prognosis.
Got it. Okay. Very helpful. Rocky Marcus is asking, with recurrent loss, 7 in a row. Rocky, gosh, that is heartbreaking. Is IVF successful with recurrent miscarriage? Where should she go now? What is the next step? Does she have hope? That's what she's really.
So definitely you do have hope. That's as difficult of a journey as you could have in anybody. The ability to get pregnant and not maintain it and happen it multiple times is just that's heartbreaking. But it is recurrent pregnancy loss, as far as a diagnosis, is actually carries a better prognosis than just infertility or not getting pregnant at all. Whether that be 1, 2, 3, for multiple recurrent miscarriages, it actually just does give us a better prognosis than not getting pregnant. And so that should give you some hope, but definitely time to start looking at things a little bit more closely in terms of an RPL or a recurrent pregnancy loss workup. I would definitely make sure I would get a saline ultrasound 3D to make sure that there's no uterine anomalies like a bicornuate uterus, unicornuate uterus, uterine septum, things like that. I would get autoimmune testing, specifically antiphospholipid syndrome, because your immune system could kind of be attacking the pregnancy. Basic hormones like thyroid, prolactin, and making sure that we are otherwise healthy, like don't have poorly controlled diabetes and things like that. And then lastly, it would be indicated to get genetics or a karyotype analysis on both you and your partner, because you both could, or either of you could carry a balanced translocation where basically part of your chromosome switches with another one, and that you would never know of, but that does give you a higher risk of having kind of an abnormal embryo and thus having, more miscarriages. The frustrating part with this diagnosis, even though it does honestly give us more optimism, is that when you do that full workup, 60% of patients to 70% will not find an answer. And in that situation, it's a little bit frustrating. And that tells us that more likely it's just a problem of the embryo and not a problem of you or your partner. So that it does give us some optimism, though, that the fact that you are getting pregnant. In terms of IVF and genetic testing, it's interesting that the more recent data has shown that there has been no increased chance of conceiving with IVF and genetic testing compared to a patient just trying on their own. And that's multiple studies have shown that. A great one out of Stanford a couple of years ago. So that's what we have to go from the data. So I think there's definitely some fertility specialists that would say, keep trying. To be honest, on my side, I would say, let's take a step back. Let's look at the full workup. And if there are other indications to do IVF, and if that woman does have a very good ovarian reserve, it would be hard for me not to say, let's do IVF with genetic testing if she is a good candidate, because there you're going to get a good number of embryos, hopefully 5 or 6 or 7, biopsy them. And even if her aneuploidy rate is higher than maybe her age would be indicated, at least you've got a lot to work with, and you're getting a better chance at least putting a normal embryo back, So, that would be kind of my.
That was a wonderful answer. And Rocky, just an offer to you, you can DM me on the Fertility Answers Instagram, and we can kind of take what Dr. Gunnala just said, jot it all down for you. If you need help with us navigating for you, where to go get your carrier screening done, where in your location to get that full workup done, we can help with that. So just free offer, costs you nothing. We offer free support, and we're happy to do that for you. So don't feel like you have to go it alone. That was such an incredibly comprehensive response. And Irvine Ashley is saying from your previous response to that one, it wasn't even her question, and she got so much info from that response. So lots of exclamation points there. We're so glad. This is exactly why we wanted to have Dr. Gunnala on the show. And then Rocky also brought up a follow-up with hers. Coffee and Glitter also has PCOS as well, on top of everything else. I mean, these PCOS warriors, these endo warriors, I mean, you guys it's such a long road. And my heart goes out to you. I mean, I literally bow down to the courage and the endurance that it takes for you to be going through every one of these things. So just know we are here for you. We'll continue to give you this type of information for free on both the app itself. So any follow-up questions you have from this, Dr. Gunnala is on the app. We have over 400 experts on the app, so you can ask these follow-up questions there too. Rocky wanted to ask a follow-up on interstitial cystitis. Did I say that right? With Hunner's ulcers.
Yep. So that's kind of one of the differentials of chronic pelvic pain. So, it could be IBS, it could be endometriosis, it could be a urinary issue. So that is a common cause of chronic pelvic pain. Sometimes it usually presents with more urinary symptoms than endometriosis, but there's definitely a lot of intermingling between those two syndromes. And sometimes a woman could think she has endometriosis, but actually if the diagnosis is not clear, or we do a laparoscopy and it's negative for endometriosis, we will commonly send them to a urologist to do a cystoscopy, look in the bladder, and then you can see sometimes classic classically those lesions of Hunter's ulcers that are diagnostic of interstitial cystitis. In terms of interstitial cystitis and causing pelvic pain, that's definitely established there. But in terms of causing kind of infertility, not so much.
Okay, that was super helpful. Lauren and C. Schultz just saying thank you. You're welcome with hearts. Lots of hearts back at you. Love that. Glad it's so helpful. All right. And then Coffee Glitter did say that she had retained placenta, and that's why she had the emergency DNC 3 weeks after the C-section. So yeah, that kind of clears that up. And that is just, oh, how frustrating, especially after already having had the C-section. You know, you expect that you got pretty good visibility in there, Dr. Gunnala. So why does that even happen? That there's some like remaining? How does that even work?
I'll take the fifth. I don't practice OB anymore.
You had your rotation. All right, we'll get an OB on to try to handle that because you think you got the best view.
It definitely can happen, though. You know, it definitely can. It's not a rare phenomenon by any means, but it is definitely strange to think about because you're right there, but it definitely can happen.
Sure. Okay, Stella had also a DNC after a C-section, then a year and a half later had adhesion removal surgery. So it sounds pretty common. Gosh, I'm learning so much today. I did not know about this. I also had a C-section. But so many of us who had to do IVF end up with C-sections. Is there data on that? And why? Do we have a perspective on why?
We don't, I think there is some small data that says there is maybe a higher risk of a C-section, but it also is probably confounded just because infertility treatment and IVF are more in women that are older, and women that are older sometimes we don't know why, but carry a higher risk of needing a C-section. So I truly don't think it's because of the IVF per se. I just think it's
my age. Hold on, it might not work. That's my son. He's coming in to say, I'm hungry. All right, we're going to take a few more questions and try to let everybody go have dinner. So Coffee and Glitter, she had a great, this is a great news. They did the procedure in September and she had her first period in a year last month. That's a great sign.
That's great.
Excellent. We're so happy to hear that.
Absolutely. Having regular menstrual cycles is absolutely a testament that there's still some viable endometrium there. So that's a very good sign.
For those of you who know, I'm a cancer survivor and I was kept in medical menopause for 3 years and was on tamoxifen during that time too. And so I hadn't had a cycle in over 3 years really, since the diagnosis. And when I got my period, my first phone call was my dad. I called him and he was at his poker circle with all of his buddies that I grew up with, like with their kids, as like the other dads in the neighborhood, and they were all cheering for me. Flow is so exciting when you haven't had it. So like, I'm super happy for you, Coffee and Glitter Mom. Oh my gosh. She said she was so happy to be on this live. Thank you. I'm so glad that you were able to make it too, and that we were able to help. This is huge. But yes, I mean, we celebrate wins like our period coming back for sure.
Yes, absolutely.
All right, let's see. We have some other folks that just joined. So just to give them quick context, we're going to try to wrap up the questions, but for those of you who have more questions about reproductive surgeries, you will be able to see this Instagram live on our IGTV as soon as we're done. And here's a great question, not surgical related, but wonderfully created. Asked, does Metformin help with fertility? Great question.
It can help with fertility with the indication if that woman has like insulin resistance and that's into a PCOS type picture. So if that woman is diagnosed with PCOS and more importantly by her kind of glucose testing and fasting insulin levels has evidence of insulin resistance, then metformin can improve that woman's fertility. But metformin alone cannot be used to get a woman to ovulate. It's not very good at getting a woman to ovulate. So we use it more for kind of just general health effects, right? So if a woman with PCOS already has insulin resistance, even outside of fertility, she has a higher risk of developing in the future diabetes. And obviously the patient's health is our primary concern. So putting that patient on metformin can help with reducing that risk of developing diabetes in the future. So that's the major benefit. But in women with PCOS that are sometimes Clomid or Femara resistant, the addition of metformin can allow them to ovulate with those oral medications. So we primarily reserve it in patients that just at baseline have some level of insulin resistance, not because of its any fertility indication, but then specifically in PCOS patients, if they have insulin resistance, we definitely put them on metformin.
I had a doctor say to me once that he could just tell you're insulin resistant by looking at your ovaries.
ovaries, I don't know that. You can definitely get, well, part of the diagnostic criteria for PCOS is what the ultrasound looks like and what the ovaries look like. But there are definitely clinical signs of insulin resistance, which we call acanthosis nigricans, which is basically kind of like a darkening of the skin at the back of the neck, or sometimes under the breast. And so there can be kind of clinical exam findings on your skin, actually, that can sometimes lead to an idea of having like severe insulin resistance.
Oh gosh, that's great to know too. Yeah, Miss. I hope I'm saying your handle right. Yeah, Miss. I think it's Mr. AT. I like getting people's handles right. Okay, great question, and we're gonna try to wrap it up. I know it's so hard because we could stay on for 2 hours, you guys. We love doing this, and we love bringing you all this good information. Do you prefer transferring 1 or 2 PGTA embryos in case of recurrent miscarriage?
In cases of recurrent miscarriage, I would then want to be less aggressive and only put 1 back. You've already given yourself the highest chance, which is not 100%, but the highest chance of a genetically normal embryo working. And so if obviously the morphology of that embryo and that blastocyst is very good, then you've given yourself, close to a 60 to 65, 70% chance of getting pregnant with that 1 embryo, which is not 100%, but it's great. The issue with transferring 2 back is that there's a higher chance that both will stick, and twins inherently carry a higher chance of a miscarriage. So if you're already coming in with that indication of recurrent miscarriages, I don't think you're gaining more by putting more back. I think you're actually somewhat hurting your chances to have another unfortunate miscarriage.
It's one of my favorite things about you and how you practice is the less is more approach with so many different areas of reproductive medicine, that you're just not overly aggressive. And that was a very sane response. And I hope you took note, Mr. 80, that is a very wise approach. And certainly with recurrent pregnancy, with recurrent miscarriage, give your clinician a chance to get the environment right, because it's like one thing at a time. You have the normal embryo, and then, get the environment right. And you just don't want to waste those embryos. They're such precious cargo for us. And there's many of us that, we have a finite supply, right? We can't always just go and make a whole nother batch of embryos. I'm 44. The only ones that I can work with are the ones that are already in the tank.
Absolutely. Absolutely.
So Lauren ECH, she has unexplained. So, it's one of the most frustrating diagnoses, I feel like, as a diagnosis, it almost says it's not a diagnosis, but it is. And she's asking, would a water sonogram show any polyps or fibroids potentially?
Absolutely. So in terms of actually meeting diagnostic criteria for unexplained, that patient has to have a full evaluation, which involves a cavity evaluation, right? And so absolutely that patient, you should need a sonohysterogram or an HSG, but some type of a cavity evaluation more than just a vaginal ultrasound to make sure that there are no polyps. In true unexplained infertility, which is, like you said, about 15% of cases, but that's where there's no male factor, the tubes are open, the cavity of the uterus is normal, and the woman's of a younger age, then, when you kind of parse those patients out, they probably have a higher risk of having some small minimal endometriosis, actually, or having a mild male factor that you can't really see on a semen analysis. So in those patients, there's no doubt that they can start with less aggressive treatment like IUIs if everything is normal and the in terms of egg count, age, and everything like that. But you may want to proceed to IVF a little bit sooner than somebody else. But I think a very good option in that patient, of the right patient, is to do a diagnostic laparoscopy, because, like I said, they're going to have a higher chance of having endometriosis as their actual reason why they're infertile, rather than purely unexplained.
I want to clarify one thing about diagnostic laparoscopy. If you do see endometriosis, do you go ahead and remove it then? Or do you have to close them up and then do it later? Okay, just making sure.
I hope not. Then that patient is going to the wrong surgeon. No,
exactly.
You want to see what you have, and you want them to
and we'll remove if there's something there to remove.
Whatever they can take care of surgically, without compromising that woman's health, and which is overall improving that woman's fertility, then you go ahead and you take care of it at that same time. But
great.
Yeah.
Yeah, Mr. Raby, if I'm saying your handle right. The question you just asked about Lovenox, in the case of RPL, when there's like 2 genetic things that came back, I'd love for you to jump on the app and ask that question so that folks like Dr. Gunnala have a chance to answer in addition to our geneticists. So we do have geneticists and genetic counselors on the app who can also help answer that question. So I just feel like she asked a very specific genetic question and would benefit from asking it on the Fertility Answers app platform. So if you haven't downloaded yet, you just fill out, takes like less than 2 minutes to fill out the health profile. And then that gets you access to asking free questions. We need the health profile so that you set folks up like Dr. Gunnala to answer with relevance. He needs to know your age. He needs to see the height and weight. He needs to know if there's any diagnoses, before jumping in to answer a question. But I feel like that's a perfect one for the platform. Coughing Glitter, I'm saying thank you so much. This is amazing. You're so welcome. Rocky too. This is amazing. Leslie, so informative. We're so grateful that you guys have jumped on. And let's see, there's a couple of all blood work unexplained for Rocky. Everything's been normal. Water sonogram is at the HSG.
Water sonogram is a SIS, which is a little bit different. HSG is actually putting an iodine contrast to not only get a cavity evaluation, but also see the fallopian tubes. Both give some information on the cavity. So I would do either or. I personally tend to do both. And I would say that in terms of just a cavity evaluation, I prefer the 3D sonohysterogram or SIS over an HSG, but both will offer some idea of what's going on.
Okay, got it. So Wonderfully Created asking, we answered the question about Metformin. So I'm going back Wonderfully Creative to see if I missed one of your questions. We're wrapping up, Dante. Hang in there, buddy. I know you're starving. Yes. So the next steps after Metformin. So she was told to take it for 6 months to see if it helped. That sounds like an OB recommendation because that's not really something a fertility specialist. But
yeah, like I said, I think you got to look at the clinical picture, and it's easy for us to kind of sit behind the chair and talk. But Metformin alone does not make a woman ovulate. You need the Clomid or the Femera or injections. You need some type of ovulation induction agent to get that woman to ovulate. But if she's ovulating normally on her own, then maybe the Metformin may help. But if she's not ovulating on her own or the cycles are irregular, then putting Metformin on there is kind of like putting on a Band-Aid on an area that never got cut in the first place.
Oh, got it. Okay, perfect. So I'm just looking, that was on Metformin, just to see if there's a couple of things here. Test Marie Bailey, genetic testing, do you recommend it? Depends on the situation, but what I recommend for you, test in that particular case, same thing, hop on the app. So just to tee everybody up who's coming for the first time, maybe we're supposed to be wrapping up in 2 minutes and we took a whole hour of Dr. Gunnala's time, which I'm so grateful for. We do a regular Monday show at 2 p.m. Pacific, 5 p.m. Eastern with another IVF doctor, Dr. Serena Chen. She loves Dr. Gunnala. She told me to tell you hi. Thank you for reminding me. She would have gotten mad if I didn't remember to do that. And then on Tuesdays, we go live at 4 p.m. Pacific, 7 p.m. Eastern with a naturopathic fertility specialist that we love, Dr. Raquel. So she covers all kinds of things about optimizing your wellness, looking at micronutrients and heavy metal detoxing, gut health, and she's integrated into fertility practices. So she works beautifully alongside any of the IVF doctors across the world. In fact, her data is amazing. And then usually Wednesdays and Thursdays are like this, where we have special guests come on, so you get a different perspective. And we're so fortunate to have Dr. Gunnala, who is an IVF specialist, but he also has a very robust burgeoning reproductive surgery practice as well. So we're grateful for you guys to have joined. Anything we didn't get to cover, come back on Monday. Tomorrow at 2 p.m. we're interviewing a fertility nurse from Embrace Fertility. So she had a long practice as a fertility nurse, and now she just supports people in kind of a holistic sense as a fertility coach as well. So I know we didn't get to everything, but come back. We promise to keep it going. And you can always ask these same type of questions on the Fertility Answers app platform, both iOS and Android. DM us if you need anything further. Dr. Gunnala, you are a gem. We are so grateful to have you be part of our world.
It's just, this is a great experience. First time. Hopefully I didn't have too many voice cracks that got caught on the web, but
you did great. You did great. We'll do it again. I promise you that. All right, everybody. Okay. We'll see you next time. Thanks so much.